Hi, this is a voiceover to talk to you about blood transfusion. This is for complex sim. Blood transfusions have been used for many decades and they're pretty safely used, but have come with some controversies. But they're used to manage hematologic diseases or diseases of bleeding. You can transfuse specific components of blood, and primarily what we see is the packed red blood cells. You can transfuse platelets, fresh frozen plasma, albumin, cryoprecipitates, as well as some of the clots. When we're giving blood, we're going to start with first, you're going to get consent and you're going to get a type and cross match. Remember that type and cross match is checking the patient's blood type, and then the cross match is it compares it to the available units of blood in their blood type. The consent is that they're authorizing that it's okay for them to receive blood. You're going to call the blood bank and notify them of the need for blood, or you may notify them through the computer. The blood bank will process the blood and get it ready. I've never fixed this on this PowerPoint, but you need an IV that's 20 gauge or larger. I don't know why it says 19. I've never fixed that. They don't make a 19. Uh, Larger bore needles may be used for rapid transfusion. So somebody who needs uh, a lot of blood over a short period of time would have a bigger gauge IV or a central line. And by bigger gauge, I mean probably a 16, no smaller than an 18. Smaller needles may be used for platelets, albumin, and clotting factors, and that would be like a 22. You need special tubing for administration of blood, and that's the Y-type tubing with the filter. It's Y-type tubing. There's a filter, and it's a specific micron for transfusing blood. Blood is only compatible with normal saline. You're going to change the tubing for each unit of blood, but if there's not a problem with the filter and it's been less than 4 hours since the start of the first unit of blood, when you're going to hang the second unit of blood, let me try that again. So if the first unit of blood is complete within the 4-hour time frame and there's enough time lapsed to give the second unit of blood, you can use the same tubing. If you use any kind of dextrose solution or lactated bringers, it'll cause hemolysis of the red blood cells. And what that hemolysis means is that the blood cells break. Nothing is ever piggybacked into the tubing. You're going to get blood from the blood bank. You never keep it on the floor. You need 2 RNs to identify blood in the patient. And improper product and client ID is responsible for 90% of reactions and problems. And the blood bank is responsible for the type and cross. Now, our hospitals do a variety of things. Some facilities have gone to the computer being the second double check. And that's okay. That's acceptable by the Infusion Nursing Society. Only 1 unit at a time should be available, so you don't store it in your unit refrigerator. You administer it as soon as possible once it gets to the floor, or if problems occur. So let's say your IV blew before you were able to get it started. That's the kind of problem. Then you want to send it back to the blood bank within 30 minutes. You cannot send it back to the blood bank if more than 30 minutes have elapsed. Blood products are always checked by 2 nurses. We already said that. You're going to take baseline vital signs, and you do that right before you send for the blood. You're going to start the transfusion. In the first 15 minutes, you run it in slowly, about 2 milliliters per minute, but no faster than, say, 5 milliliters per minute. Usually that works out to be about 75 mils per hour on the pump. Monitor for rashes, fever, dyspnea. Most reactions occur within the first 15 minutes. After 15 minutes, take the vital signs again, and then you can increase the rate of the transfusion to infuse over the remaining over 2 to 3 hours. Take your vital signs every 30 minutes until the transfusion is complete. Document in the narrative notes to include date, time, vital signs, assessments, and signature. If a second unit is to be transfused, you're going to start the process all over again. Transfusion reactions, there's two types of reactions. There's the hemolytic and the non-hemolytic reaction. The non-hemolytic reaction are the milder reactions, and those would be the fever, the rash, the headache. They're generally not a problem. Sometimes you want to slow down the rate, and you want to treat them symptomatically. When you're slowing down the rate, it still has to transfuse within that 4-hour time frame. It's usually associated with multiple allergies or somebody who gets frequent blood transfusions. People who need regular administration of blood products, they're generally pre-medicated with both Tylenol and Benadryl. And document and continue with transfusion. The hemolytic reaction or the ABO incompatibility is a true reaction and is life-threatening. It can be due to an error in the type and cross and the patient ID. Complications of transfusions are very significant, and it's a pretty rare problem. Usually occurs within 15 minutes of the beginning of the transfusion, but it can occur later. What happens is the patient becomes very unstable. They may start to develop chest pain or a spike of fever, or their blood pressure will drop, or their heart rate will go crazy. And so you want to stop the blood immediately. You want to get a different tubing and hang a saline to transfuse it into that line. You're going to notify the provider and the blood bank right away. You're going to do double checks again, recheck the ID, the patient ID. You're going to monitor their vital signs and their urine output. Part of ABO incompatibility is it causes hemolysis of the blood cells. And what can happen with that is that those red blood cells, those broken cells, can get stuck in the capillaries of the kidneys. And because they're larger molecules, they don't filter, and you may see hematuria occur. You're going to treat symptoms. Usually, we're going to give fluid bolus and stabilize the patient. You're going to get blood and urine samples, send the bag and the tubing back to the blood bank, and you are going to complete an incident report on this reaction. Other complications include fluid overload if they're getting a lot of product over a short period of time. Again, fluid overload also could lead to congestive heart failure. Sometimes when people have a history that would lead to heart failure or overload pretty easily, they'll get a unit of blood and they'll follow that by some furosemide, is how the order will be written. They're at risk for air embolism, they're at risk for infection. Hepatitis is the most common complication. Blood is tested for hepatitis, but sometimes the screening doesn't allow for the time for it to seroconvert. Malaria, CMV, and HIV/AIDS are also potential problems, but all of those are pretty rare because the screening processes are so much better. Other complications, cardiac or renal insufficiency, and I've already said this, large quantities of blood can cause major problems. Hypothermia, blood is stored in the refrigerator under controlled temperatures, and so if you're giving a large quantity over a short period of time, that can result in the patient becoming hypothermia, and that can also lead to the other problems, the citrate toxicity and hypocalcemia. Citrate is the anticoagulant used in the stored blood to keep it from clotting, and what the citrate does is it'll bind to calcium. And so if there's too much citrate circulating because of all the blood product, all the patient's calcium is going to bind to that, leading to hypocalcemia, with the primary concern being life-threatening dysrhythmias. Also, if they have hemolysis happening, the breaking of those cells, the blood cells, that's where the potassium is stored, and that can lead to hyperkalemia. Autotransfusion is there's no problem with incompatibility and or allergic reactions or problems. It can be the patient scheduled for surgery and they go and donate their own blood. and it can be stored frozen for up to 3 years. And it's not put into general blood supply. The other auto transfusion way is somebody who's bleeding a lot. If it's not an abdominal injury, it's not an abdominal injury, then they may collect the blood through the auto transfuser and then reinfuse that blood to the patient. That's the end of this PowerPoint.